1.
Good morning, everyone. Thank you for being here. Sorry that we're unavoidably delayed a little bit this morning. I want to welcome you to the 17th Annual Cerebrovascular Symposium and also Neurology Grand Rounds this morning. This is the William Lukowski Endowed Lectureship and the kickoff to the Cerebrovascular program, and it gives me great pleasure to welcome Dr. David Liebeskind here. He is a longtime friend of Seattle Neuroscience Institute and SSF, frequent guest of ours, and always delighted to see him. He is the director of the UCLA Stroke Program, past president of the Society of Vascular and Interventional Neurology, and a world expert on stroke that we are very privileged to have this morning. And so without further delay, David, thank you for being here.
Thank you very much, Cameron. So it's a pleasure to be back again. I've been here a handful of times at the symposium, and I'm going to speak to you about a topic that I've spoken to you about before, but one of the main emphasis points is that the science doesn't get old. The science of strokes continue. What adapts is how we change over time in terms of the treatment, and more recent evidence that tells us how we can do things perhaps a little differently. So I'm going to speak to you about collateral circulation in acute stroke, specifically in a larger term, collateral in acute ischemic stroke. What do we have in terms of available to treat patients with different degrees of residual blood flow when they present, different types of strokes, different extent, and how the field is evolving at this point from the standpoint of diagnosis, as well as how we refine our therapies to best treat each patient that we see. So the grand overview is that there's a lot of new data, a lot of very new, recent new data. The landscape of stroke has changed considerably over the years, and there are new approaches, and I should say not just approaches, but combinations of approaches to treating acute ischemic stroke. Probably the greatest emphasis very recently that is emerging is in terms of adjunctive therapies for acute ischemic stroke. What used to be termed and bucketed under neuroprotection, which I was and many of us were involved in 25 years ago and more, has ebbed and flowed but persisted. There are several different trials going on right now of cytoprotection or neuroprotection. As I'll mention, I like to avoid a specific terminology in terms of the medications being used that are based on mechanism, because we don't often understand the mechanism of these drugs and what they do in the human brain until they're given to patients with acute ischemic stroke. So the drugs may not act as their mechanism implies when they're studied at earlier stages. But in general, these are adjunctive drugs largely because they're given in adjunction to thrombectomy, which has become the mainstay of acute ischemic stroke. So this has changed. It took a long time for this to change. Historically, endovascular therapy was something that was actively underway 30 years ago at UCLA. I remember these cases from back then, and it was way before we had randomized controlled trials that were ever dreamed of and thought to be done to prove that thrombectomy works in acute ischemic stroke. As you know, 10 years ago, we reached that point where we had overwhelming evidence that thrombectomy worked. But at that time, it was with very limited types of strokes when patients presented with relatively smaller core infarcts, smaller strokes, that were sort of the ideal candidate in terms of outcome. And what's happened over the last decade is that we've learned that we can apply this approach for reperfusion using thrombectomy to more and more patients around the world with perhaps larger and later strokes from a time window standpoint. I say this often, but I do take it very seriously that science can be stored. And what I mean by that is that the science, the underlying biology, the pathophysiology of stroke doesn't change over decades. It doesn't change at all. It takes a much longer time course to change human biology and the pathophysiology of stroke. Collaterals have been around forever. Where the perspective is a little different is in terms of how people speak about collateral circulation and from a practical approach, how we're using collateral circulation in acute ischemic stroke. So this is an area of the field that I got involved in many years ago, more than 25 years ago. I thought it was a very curious aspect of stroke, that being collateral circulation to the brain. And a lot of the time was focused on what the circuit of blood vessels was doing in terms of providing supplementary or adjunctive flow when the primary vessel was blocked. And even 20 plus years ago, I thought it was very important to emphasize the role of collaterals in terms of what could be done and specifically delivered in terms of therapies of neuroprotection at the time. A lot of debate about the fact that these agents were delivered through the bloodstream, and of course that was the problem in itself, is that a certain region of the brain in acute ischemic stroke was lacking blood flow. So therefore the only way you could get the drug there would be via the collaterals. So we did a number of investigations in terms of a delivery of agents, putative neuroprotective agents and others to the downstream region to try and figure out what would be the most effective delivery and how effective would it be. And what we've learned over time is it's a portion, it's a piece of the therapy. It's not the mainstay. It's not something that could ever replace thrombectomy or revascularization in general. There is a little bit of a market strategy to the study of collaterals and collateral therapeutics. And what I mean by that is that, sometimes we think of things being very different in terms of the academic research labs, where we write papers that lead up to successive grants, and differently perhaps than in the routine clinical practice, where we look to what we have in terms of therapies, whether it's a medical device or a drug, and we ask, can we use this? On both fronts, what we're faced with is, in terms of collateral circulation, is not just the study of collaterals, but so what are you going to do about it? The so what question. So this so what question comes up very commonly, actually in NIH grants, where you can say that you want to study the science of collateral circulation, the imaging, understand the mechanisms that are at play, and how you can leverage this to take patients to the next step in terms of improving treatment. And we often get asked back in review, well, so what? What is the product? How are you going to change the field, not just study it? So even in the purest of academic disciplines or fields of work, that question comes up. The practical questions come up all the time. So I think of things from a very practical standpoint in acute ischemic stroke. Stroke science is an applied science. It's how we apply what we understand at the bench and in other settings and apply it to best treat our patients in front of us. And to do that, we really have to focus on another entity that I've been involved in for a long time that has sort of been euphemistically portrayed as, and that is precision medicine. Precision medicine is really pairing up, in its most basic terms, the diagnostic information of how one patient presents, their imaging patterns, specifically here in acute ischemic stroke, with specific therapies. So moving away from this concept that, that you have treatment X and that treatment X is good for all stroke patients. Not all patients with stroke present with the same type of stroke. And even when you subdivide in terms of something like a large vessel occlusion that's causing an acute ischemic stroke, a proximal occlusion of an artery in the brain, such as the MCA or the ICA, distal ICA, in those cases, the patterns and the imaging is very different from one patient to the next. So when that patient presents early or late based on imaging and based on time, we may have different therapeutic options available. And if you try to apply the same therapy or treatment, the same device or the same drugs to all the patients the same way, you're not going to get the same outcomes. The outcomes are an intersection between those two. Finding the right diagnostic criteria that patient meets and pairing it with the right therapy. So you have to be able to balance those two. And that's sort of the root of where precision medicine sits. So how does this apply to collaterals nowadays and very recently in acute ischemic stroke? Well, I've listed out a couple of things here that I think are, to me, very curious, because I think there's some of the most pivotal changes that have occurred in my career and have yet to occur. We're at this juncture point now where, for the first time in a long time, pharma, so to speak, the pharmaceutical companies are regaining interest in the field. And this is what I like to refer to as baby pharma, because it's not the large pharmaceutical companies that haven't been as present in the stroke field for a long time. Because stroke is still a small field. It's hard to predict when the next acute ischemic stroke patient is going to come in. It's periodic. And they have really, there's not been much initiative in terms of large-scale pharmaceutical approaches to acute ischemic stroke, other than preventive approaches. So baby pharma, the smaller pharma companies that have developed in a similar way to the way the baby device companies, the startups on the device side in acute ischemic stroke has seen over the last decade or more. So there's a role, as I'll explain, for adjunctive therapies and what's being done on the baby pharma side. There is also this entity of futile revascularization. So even when we decide that we're going to take patients to the angio suite and revascularize them, it doesn't always work. And this is a little bit of a philosophical debate in terms of what is futile recanalization or revascularization, and can we really call it futile or not? I tend to shy away from that a little bit because I don't think it's futile. It's something that you decided to do, and it's very likely worthwhile, but it may not completely cure the patient from the stroke at where they were based on how they presented with the extent of the ischemia. So the other 2 points in terms of collaterals that I think are very interesting are when you have intracranial atherosclerotic disease, you have an interesting situation when you have stroke due to atherosclerotic disease, not due to a cardioembolic lesion, not clot going up to the brain to a distal vessel. You have a situation where you have a chronic disease that is now presented with an acute manifestation. The person's much worse. All of a sudden, they may have been asymptomatic this whole time while they're developing the disease in that upstream vessel. But all of a sudden, they become, they succumb to the ischemia. And often, when we see these people, yes, they are having an emergency medical scenario. They have an acute condition that has to be treated, and sometimes it is in the form of complete occlusion of that vessel that has now gone from a plaque or a narrowing to a complete blockage. But beyond that, the interesting part is that these patients, because they've had chronic disease, develop better collaterals over time. So you have this conflict or this paradox where patients are having an acute emergency situation, so they may be in a severe state, yet their collaterals are somewhat better than we might expect in other situations. And what do we do? It is a conundrum because these patients may fluctuate, they may do better, we may not want to be as aggressive about it, except for the fact that they are presenting with an acute emergency scenario. And then finally, the imaging methods and the focus on collaterals, which frankly has been the focus of my talks for many, many years, where the goal has been to use imaging and different imaging methods to look at collateral circulation in greater degree, to quantify it, and with different methods. But the problems with that are that people use different imaging methods. One imaging method may be better than the other, and people still come back to that practical question of the so what? What are you going to do about that pattern that you see? It's nice to study it from an imaging standpoint. You can get automated maps with the various vendor platforms nowadays of the perfusion. But what are you going to do, and how is it going to change your management? So it still comes back to the very practical aspects. So touching on precision medicine again, precision medicine is this intersection between diagnostics and therapeutics, the Theranostics, so to speak, where we look at what we have with a specific patient when they come in, the imaging patterns, and figure out what's best for them in terms of the therapies. And again, the therapies may not be just going to thrombectomy, but there may be a need based on larger core to do more. Now, this is very different than when we think about how therapies have been developed in the stroke field. So TPA has been around for 30 years. I remember, I started giving TPA in the first year that it was available, and it was interestingly developed at the same time and almost a little bit later than endovascular approaches for stroke. It took much longer to prove endovascular therapy than it did IV thrombolysis, and for practical reasons as well. IV thrombolysis was much easier. Quite frankly, you just had to have a clinical diagnosis of stroke and nothing else. You do not need, and still do not need, a target vessel occlusion or arterial occlusion. It could be any type of stroke as long as they meet clinical criteria. It's reasonable to treat them with a thrombolytic drug, and that's the be-all, end-all sum of it. Endovascular therapy, however, is almost the opposite or the antithesis. You needed to see, in certain cases, a upstream or proximal arterial occlusion in the brain to go after, to try and reopen. You had to see the vessels. Some would argue you had to see the perfusion pattern or not, to look at the blood flow pattern to see whether it's worthwhile going in to treat these patients, and of course, based on around their clinical presentation. The development, the therapeutic development of neuroprotection and cytoprotection, adjunctive therapies, has been sort of on the back burner for a while, as I've mentioned. This is an area where we've wondered how the drug gets there when the vessel's blocked. Well, it's via collaterals. How is it best, and when is it best delivered? Are these adjunctive therapies best delivered prior, during, or after thrombectomy? Unclear. What we've learned most recently is probably not necessarily all before without treating that large vessel occlusion, because unless you get prompt revascularization or reperfusion, the outcome may be swayed against the favor of, or against the effect or the marginal effect of just using a drug alone. So the timing matters. Mechanistically, it matters also in terms of what the drug is specifically doing in terms of the reperfusion and how it's protecting or preserving the brain. So collateral circulation is a great topic to focus on if you like pretty images, because we can image it in many different ways and characterize it differently. This has been sort of the target of a lot of criticism in the sense of, we're just looking and playing and demonstrating the collateral circulation without offering something practical in terms of therapies for patients. On the left, you see a schematic of a proximal M1 occlusion. The lighter area in D is the core, conceptually that we think of, that when someone says, draw a map of what a stroke, an acute ischemic stroke due to a large vessel occlusion looks like, I think of this. I don't think of schematics of the brain. I think from a vascular standpoint in terms of blood flow territories and corresponding collateral territories. So the collaterals come up over, in this case, not just the Willisian collaterals at the circle of Willis, but the collaterals that come over the hemisphere. The collaterals that come from the neighboring arterial blood flow routes that course back through these connections over the surface of the brain and then actually deliver blood flow in reverse or retrograde fashion. So people have argued, that's not those aren't collaterals that we often point to on an angiogram because they're in the primary territory that's blocked. They're immediately on the other side of the blockage coming in reverse. It's true, those are not necessarily the collateral anastomoses, but it's the collateral circulation pathway that then develops, and it becomes the primary territory of the brain until you reopen that vessel. So there's a lot you can do in terms of imaging collaterals, but again, the question is really focused on therapy and how do we use this. So precision medicine can be thought of in terms of doing, what's right therapeutically for the right patient at the right time, the right medication, the right dose, or combination with drug and device, doing things just all right. So this does start with imaging. It starts with understanding, where that patient is at, how large that stroke is. The two strokes shown below are both right MCA strokes at the same time point. Very different patterns of injury. And the patterns of injury in the brain are important because everything from an imaging standpoint is pattern recognition. But it also tells you what the options you have available from a therapeutic standpoint. What we've learned from an imaging standpoint in the two different images shown on the left and the right, would be that the core and the penumbra sit in different areas. And this very simplistic model that I showed you on this earlier slide of the angiogram with a core at the base and the penumbra in this slightly darker region around it doesn't really take place that way. To some degree, in a larger macroscopic scale, it does. But even on the image on the right and below, within the larger ischemic field, it's heterogeneous. So there's areas that are more severely affected and areas that are less severely affected. So there are what people like to call microcores, or smaller populations of cells and regions of the brain that are more severely affected, and those that are less severely affected. So precision medicine is not new. Precision medicine was something that developed from the Human Genome Project now 24 years ago. And in stroke, we don't run acute diagnostics in terms of our genomics. Maybe in the future we will, but at present we don't. And the precision medicine is based on the precision of the data that we have. And the data, the currency of the data is imaging. Imaging and basic clinical variables, not genomic profiles. So it involves how a certain patient of a certain age and sex presents with a certain imaging pattern, what their degree of collaterals is, whether they have diabetes and other factors, and trying to find out precisely how to best treat that one patient. So collaterals are important. This is something I've glossed over, but so why do patients present with different patterns? Patients present with different patterns of ischemia in acute ischemic stroke because they have different degrees of collateral circulation. We still don't know why some factors like diabetes are set up for worse collaterals. And all these things, as you can imagine, are multivariable. It's not just one variable. It's the age alone is not necessarily the most important variable. One comorbidity alone may not be the most important. And people have delved into collateral circulation from a genetic standpoint. Are people, we know that certain strains of mice and rats have better collaterals than others. But it's a combination of all these factors. So from a practical standpoint, where the imaging comes in is similar to an NIH stroke scale score in acute ischemic stroke. There's no debate about what necessarily, or concern about what led to it at that point. You're given a certain presentation of a stroke patient at that time, and you have a certain amount of information. And this will be important when we think about what's happening now in terms of large core stroke and the recent trials and how we treat those patients. Because we don't have an option of sending all patients, anybody that's designated as having a large core stroke, please don't come to our hospital, go across the street to the next hospital. We have to make responsible decisions for how we treat every single patient that comes through our door at any hospital. And that's why we have to tailor our therapies. We don't just offer one therapy or one drug. We have to think about how we tailor what we do for different patients. So the role of collaterals is important. We've known this for a long time. In Hermes, we looked at this. This paper will be coming out finally after many, many years, looking at collateral circulation at angiography in acute ischemic stroke, done many years ago now. So with highly selected patients, even then, the degree of collateral circulation had an impact in terms of outcome at day 90. So how good your collaterals are at baseline is an important factor in terms of how you do 3 months later. So I mentioned some of these variables. The variables including basic demographics, as well as comorbidities are important in terms of determining or figuring out how one patient may have different collateral status than the next. The time and severity are not determinants of collaterals necessarily. So there is a time course to collaterals, but patients that present at the same time do not have the same degree of collaterals. There's a very broad range, and the severity is a direct reflection. When you have the same vessel occlusion at the same time, the severity, the NIH stroke scale score is a direct manifestation of how symptomatic you are because of collateral failure. So we see scenarios where you can have a complete occlusion of an upstream vessel in the brain and have no symptoms. And one of the things historically that was always very curious is that people would say, oh, the person, technically has not had a stroke. So when did the stroke occur? And people have jumped around this and danced around this issue for a long time. When people have resolution of symptoms, people have similarly argued, well, we can reset the clock because the stroke hasn't been around for as long. There's no such thing as that in biology. There either is or is not an arterial occlusion. It's the collaterals that have fluctuated and have determined both the severity as well as the symptoms and the time course. How are we using collateral status? We see that patients with different collaterals have different trajectories. I'll admit that for the most part, we haven't. We've been highly selecting patients on imaging patterns indirectly with collaterals and then deciding what to do. And largely not treating these other patients that have poor collaterals. That's exactly where the opportunity now sits with the most recent data in terms of what we can do both from a device side as well as from a drug side. And of course, drugs and devices have to be proven in clinical trials. So collaterals have been shown in the past to improve spontaneous recanalization, reperfusion, decrease hemorrhagic transformation because the severity of the ischemia is less. And you revascularize or reopen the vessels sooner rather than later. The blood flow overall is much higher and better, and overall leads to better outcomes after acute ischemic stroke. And that's really where we hit an impasse. So thrombectomy really hit a dead wall, so to speak, in terms of not should you treat this patient, but how effective is it? So Hermes was termed because the H and the E were for highly effective. What it stopped short of, it's not a cure. And of course, when you think about patients presenting with acute ischemic stroke with various sizes of infarcts, it's tough to ask, whether we can cure that patient with a thrombectomy. We don't know whether we can cure them with any specific medication. And the goal is really not to be able to, we would like to be able to cure patients or get them as close to a cure as possible, but how effective can we be? And what we've learned is that there is a limit in some cases, that opening up the vessel alone may not be enough. And the choice is not simply medical treatment versus endovascular because the medical treated patients do better. They don't. They do worse, as I'll come to. They do worse because their imaging is worse when they have larger infarcts. So the imaging is important. We can image collaterals, as I mentioned several times now, with a variety of methods. I like to be practical, as I mentioned before. We use CT, multimodal CT and MRI. What we do with this information is very different at the time in routine clinical practice, and at the time that we enroll patients in clinical trials is very different than what the imaging actually shows. Now, that may seem like a strange statement, in terms of what do you mean we see the images acutely and what the imaging actually shows. So I've run an imaging core lab for many, many years in a lot of stroke trials, and when you have expert eyes looking at the images, it's very different than what you see from a routine standpoint. People have sought in recent years to look at automated imaging approaches, platforms that can automatically give you through perhaps some degree of AI, just a quick and dirty read, and it's good for that. As long as you take it with the recognition that it's a quick and dirty read, and it can be wrong. In clinical practice, you still want to look at the images and make sure that what you're getting as an automated result on multimodal CT or even multimodal MRI is correct. I'm not going to run, for the sake of time, through the various imaging depictions of what we normally look at in acute ischemic stroke. But with CT as well as MR, it's a combination of parenchymal imaging to look at the degree of injury in the brain, which we may see more or less of depending whether we go to MRI or CT, the site of the arterial blockage, and the perfusion patterns. I'm going to skip over this, but just in a couple of these slides, but just to say that we still are not thinking about the goal of what we're doing with that imaging. As I'll show you on the perfusion imaging, simplistically, we can see that that when you have a vessel blockage and you do a perfusion study, you can see that there's a perfusion delay, and that delay may vary, and the pattern is what counts. Some groups have gotten into this in terms of the degree of collaterals based on the perfusion patterns, Again, that's a gross indirect assessment of what you're seeing in terms of collateral circulation. You're not directly imaging the collaterals. You're indirectly imaging them. It's a pattern. And that pattern may help you in terms of treatment of the patient, in terms of categorizing that patient as really bad or really good, but it's not going to tell you exactly what to do. And this is where, as healthcare providers, we still have jobs in terms of making those tough medical decisions about what we should be doing for those patients at that time. So in terms of endovascular therapy and the need for additional therapies, one could argue are we done? I think recently with the large course trials, I think the answer is no, we're not done, and we've uncovered an area that some have not wanted to uncover for a while, because now we realize we can treat all stroke patients that have a proximal upstream large vessel occlusion with thrombectomy. Are they all going to do well? No, definitely not. How could we expect that they're going to do well? We thought in the first place that they're not going to do well because they have larger strokes. But the trials and the way that they were done, and I say this with very recent news, we have 5 out of the 6 trials now published. We have one, the Tesla large core trial that'll come out in a couple of weeks. But the last, or in extremis, large core trial was published yesterday in the New England Journal, and it shows that with cores of any size, that thrombectomy, when compared to medical therapy, can benefit those patients. Again, the outcomes are not perfect outcomes, but the outcome with thrombectomy is better and far better than by not doing anything. And euphemistically, we say, oh, best medical therapy. There is no best medical therapy. We don't have a good medical therapy. And then we put people in the neuro ICU, we manage them through it, and we had a heated discussion about this yesterday where we all agreed in the end that all we're doing in the neuro ICU is managing complications of the stroke. We're not reversing that stroke. We're not actively treating that stroke necessarily. So it's very important. Neurocritical care is the basis of all phases of these acute events when you have ischemia in the brain. However, if you ask, are you reversing the offending injury or are you mitigating the consequences, it's much more the latter. We're really limiting complications and doing what we can to contain what is the injury that's already evolving. Some topics that I mentioned adjunctive therapies, which are very important. I want to refocus on, in addition to large core, distal occlusions. We have colleagues that are very excited because now the latest thing is more distal occlusions. There's just suffice it to say that there are several trials. There's 8 trials now of more distal occlusions. There's terminology differences in terms of what we call a large vessel occlusion versus a medium vessel occlusion. From somebody who's measured more vessels than anybody, people don't measure vessels. And this is like the terminology of large, medium, and small. It implies a size. And actually what's being measured and described in these studies is not based on size. So I think the terminology of a medium vessel occlusion is a misnomer. It's an improper term because nobody's actually using the size. It's how far downstream the lesion is. It's whether it's distal or not. So I prefer the terminology of distal occlusions. And these are different lesions in different parts of the brain. And there are a number of trials that will be presented. The first will probably be presented at the stroke meeting next year in Los Angeles. And they're not looking at one specific device or one specific therapy. They're looking at how these patients do overall. So we're going to get some basic information, but it'll be a few years before we get very detailed information about how one specific therapy works versus another for these distal occlusions. I mentioned ICAT as well, where the collaterals are very different as well. I'm going to skip over the, well, actually, let me go back to, if I can, to this slide for a second, which comes back to this point about definitions. What is a large stroke? What is a large core stroke? The simple answer from me, at least, is that in the last 6 trials that we have of large core stroke, so to speak, it varies. The definitions that were used were different. How they were defined when patients were enrolled is different than what was seen from a core lab standpoint. What imaging was used, CT versus MRI, whether it's aspects, whether it's automated imaging, whether it's perfusion or not, these definitions do vary. So you have to be very careful in terms of what you're calling a large core stroke. So I'm going to jump a little bit ahead to this, because this is where I think that the opportunities lie. So the two topics that I mentioned that were seemingly distinct in terms of large core stroke, these patients that present perhaps at later time points when the collaterals are starting to fail already, or with more compromised collaterals even at an early time point, may have larger strokes. Those larger strokes may limit the opportunity that we have to treat these patients. That's one aspect. The second aspect is, what else can we do for these patients in combination, even if we decide to treat them with thrombectomy? And these are two areas where collateral circulation become incredibly important in terms of what we're doing. As you can imagine, the simple answer is not so simple. There's not just one right thing to do. There's a combination of things to do. From a precision medicine standpoint, we have to think about how we have a variety of different types of patients presenting with different diagnostic imaging patterns, and how we tailor many different therapies to those patients. So when it comes down to adjunctive therapies, I mentioned earlier that we were looking at neuroprotective therapies and how they're delivered via collaterals while that vessel is blocked, shown in the schematic on the left above. And it's a very interesting science and study in terms of if you try and measure exactly how much blood flow is delivered to certain areas of the brain, the nature of the delivery pattern, and how much neuroprotective or adjunctive drug are you getting to those regions. And the answer is, it's not an easy delivery route. Probably the simplest answer is that it's not very effective if you leave that proximal vessel occluded. Because it's much more efficient to perfuse the brain, and that's why our arterial circulation of the brain is designed this way, to go from a main pipe out to smaller branched vessels and distribute in that fashion, than rather deliver via in a reverse fashion into the field. So the delivery of collateral therapies matters a lot. It's all somehow related to blood flow. Questions have been asked about, can we stimulate collaterals? Can we do something to the collateral circulation itself to enhance the blood flow? Possibly. By stimulating collaterals and vasodilating them, you can't grow collaterals acutely, but dilating them up to a certain degree, you may have different capacity to deliver different amounts of blood flow and things you can put in the blood, neuroprotective or cytoprotective agents. What is the impact in terms of on no reflow or limited reperfusion or futile revascularization? It remains unclear, as is the definition of what is futile revascularization anyway. Coming back to that point, that terminology about futile recanalization or revascularization, I don't think it's futile. In most cases, you're doing it because you thought it was indicated, and it just may not be a cure, and it stops short of that. So I think we have to move a little bit away from trying to cure the patient with one therapy, with thrombectomy or a drug alone, and think about how we do this in combination. So the two topics feed right into each other, and they both relate to collateral circulation. Large core stroke is generally a field of poor collaterals. These are patients with limited or not as robust collaterals. And then you have the neuroprotective or adjunctive drug role or side, where you're attempting to deliver these agents or drugs via the collaterals in patients that don't have the best collaterals. So that's a tough challenge. How do you do that? And probably it's not, undoubtedly it's not easy, but you have to do this in combination. So what's happened in terms of neuroprotection, and I'll come back to this in a moment. In recent years, everybody, 25 years ago and more, there were there was one neuroprotective trial after another in patients with large core strokes. I enrolled patients in the late 90s and the turn of the millennium with large, humongous strokes in trials of neuroprotection. It didn't work. The reason those trials didn't work was because they were designed incorrectly. Because those patients would not benefit at that time when thrombectomy was not even proven, so to speak. And we were told that we shouldn't look at a CTA to see whether there's a large vessel occlusion because that wasn't proven, and that we shouldn't necessarily revascularize these patients. We should just treat them with a drug. Yeah, that was probably futile. There had to be a recognition that opening up the blood vessel was important to some degree. And also not targeting those patients that are just very severely off to begin with without something that can actually make them even slightly better. But what did evolve after that was a period where everybody, oddly enough, put all their hope in one neuroprotective agent for a while everybody was busy working on endovascular approaches and revascularization and how to improve revascularization, only some were really working on neuroprotective and fairly quietly in the background. The drug neranotide was being studied in a series of studies and trials that, suffice it to say, ended in what I would call failure. A failure of a trial, unlike failure of a therapy, is when you get a negative trial, a trial that did not show a positive outcome. That is a failure because it's an attempt. Those trials actually showed that the drug didn't do what they thought it would do. And it's not because of the drug, in my opinion. It's because of the trial design. And they were largely focused on patients with preserved brain, limited core, and put another way, treating patients that didn't need their drug. When you develop a drug, if you're going to market a drug for collaterals or for a neuroprotective or adjunctive therapy, you have to know who your customer is. And those weren't the customers. The patients with strokes that could respond to thrombectomy don't need another adjunctive drug. So this is where the two topics come together, because now that we have evidence that we need to do thrombectomy in a lot of these patients with larger core that have poor collaterals, those are exactly the same patients that we should have been targeting with adjunctive therapies. So the biggest boon of the large core strokes is actually paradoxically not for endovascular therapies. Because there's still concern about, should we be treating all patients? The outcomes may be bad. There's a huge impact in terms of the workflow in the United States and elsewhere around the world. But the real impact is, what does it mean for the drug companies and for pharmacological approaches and adjunctive approaches? And this is where I think there's a pivotal change coming in the field. In terms of when do we give these drugs? Do we give them at the time of revascularization? Do we continue them in the neuro-ICU? Do we continue them for 5 days? Unclear. We don't know. And this is where a lot of groups are digging in the last 12 to 18 months, much more so. I'm going to skip over that and say that there's a lot of implications in terms of collaterals. We speak about collaterals. I have a conference that I've held since 2012 every year. We're doing a lot more in this year in 24 and beyond. It keeps on growing. It's a global conference where we pull in people that use collateral circulation in different aspects, in very basic, limited aspects in parts of Africa, to much more detailed forms in the angiography suite, in terms of device development and drug development in other settings. So I welcome you to join us both in person as well as virtually, but it's really a study of all of stroke, and that is in essence what Collaterals is that it's learning how we can use the various approaches and features of stroke to best treat our patients. I'll stop there so there's time for some questions.
Thanks, Dave. Thanks for coming up and fantastic talk, as usual. I don't know if you remember, there was an article maybe 10 years back in ICAD. It made me, your ICAD slide made me think of this, where they were doing forearm preconditioning, ischemic preconditioning. I think it was a study out of China, and it had some magnificent outcomes in people with ICAD. And something that I've noticed is people that are chronic smokers, who kind of have that chronic ischemic conditioning, they have these big cores, or they look like they're going to be big cores, and you reperfuse them, and then they have nothing on their DWI. Is there a component of ischemic preconditioning that you guys are seeing too with regards to the collaterals and people that you guys are studying?
Yeah, so it's an excellent point, Jens, and thank you for having me up and visiting today. There are different approaches to that topic. One is the question of ischemic conditioning and what happens. When you have acute on chronic and repeated chronic ischemia, you do have ischemic preconditioning that takes place. Its role therapeutically remains unclear. It's not something that's commonly done in the United States. I've participated in a number of trials in both ischemia as well as hemorrhage. There's in a couple of weeks at ESOC, at the European Stroke Conference, the latest intracranial hemorrhage trial using ischemic conditioning is going to be presented. Quite frankly, I don't think the results are very surprising. It's in the sense that hemorrhage is a very difficult entity to target. It would be much more direct with ischemia. The difficulty is proving that it has a role because of the nature of these patients and how we see these patients. They don't come in with a clean history and all of a sudden present with an acute ischemic stroke with a complete occlusion and respond the same way. So it's difficult because going back to what I mentioned earlier in my talk, these patients are having an acute event, but their collateral circulation has had time to develop and maybe somewhat better. The interesting environmental as well as comorbidity or inherent problems that people present with, the two big ones in terms of collaterals are smoking and diabetes. And their effects are quite different. Smoking throughout various vascular beds causes the proliferation of collateral vessels, but they're not as effective, so to speak. So you get like Berger's disease, you get a proliferation of an angiogenic or arteriogenic response. But in terms of the bulk, large volume delivery of blood flow, are they as effective? No, not really. And you still have, anybody that continues to smoke is going to continue to have that risk of ongoing ischemia anyway, and vascular disease. In recent years, for a long time now, we don't see very much smoking anymore, which is great. I'm often struck by this when I travel and I go overseas. In Europe, it's much more common than in the United States anymore. When it comes to diabetes, that's an interesting question. 10% of not just this country, but 10% of the world population at a minimum has diabetes and formally recognized as such. When you start to talk about glucose intolerance and metabolic dysfunction, that percentage is much higher. And so it's a chunk of all vascular disease. Patients with diabetes also have impaired collaterals. Why? It's unclear. It's not clearly the same mechanism of how hypertensive rats, the SHR, develop worse collaterals. The mechanisms are somewhat different in terms of what they're doing to the collaterals, but the patterns are different. So coming back to your question, we don't understand it very well in terms of the role of whether it's ischemic conditioning or ischemic conditioning could be looked at as another adjunctive therapy. Here you have a device that's being used to possibly improve collaterals over time, depending on when it's applied. Or in terms of how do we make patients who have collaterals better, somewhat unclear.
Again, enjoyed your talk. Thanks so much. I was intrigued, though, by your comments on neuronitide and obviously the interplay of neuroprotective agents and collaterals. My simplistic thinking was always that a lot of the failed trials in the past was, well, what do you expect? You never revascularized, you gave a drug, and you never did anything after that. It seemed to me like the original neuronitide trial that there was a positive signal in the patients that didn't get TPA and dissolved the drug. And then the Escape Next, the little bit of a signal there, the Frontier trial looked positive. Help me put it together. What you said the design was wrong. What's the right design? Do you think the drug works, or?
I think there was a little bit of a back and forth in terms of, the investigators knew that there was an interaction with TPA. So if that were the case, and they really wanted to avoid that, and it's a choice when you design a trial. The earlier trials were designed to include TPA because they didn't want to limit patients that didn't get TPA, but they knew at that time that there was an interaction. So subsequently, as you mentioned, Cameron, that then there was an avoidance of the TPA, and then there was a debate about what does the TPA do and what's the effect of the TPA, and you're selecting the wrong patients based on that. I think we make an assumption in terms of what thrombectomy does, what thrombolysis does, and what a drug does based on what we call them. A thrombolytic, most thrombolytic agents, and my colleagues get very upset when I say this, most thrombolytic agents, when given to patients with acute ischemic stroke, do not thrombolyse. And that's a problem. So that's why I don't like to call drugs specific names based on mechanism, because when you have imaging evidence that they didn't do what they say they were going to do, well, then that's not the mechanism that they're using. So the issue of thrombolysis was one factor. The thrombectomy problem, it's not a problem with thrombectomy at all. It's the opposite, is that thrombectomy works.
Right.
It's that the trial design, 50% of patients in Hermes had no infarct growth now 10 years ago, treated around the world from baseline to 24 hours when they had revascularization. Revascularization has improved since then. So if 10 years ago, half of all patients that went to thrombectomy had no infarct growth, well, are those the types of patients that would need a drug? No, because they didn't grow an infarct. So there's absolutely no need why they would need anything adjunctive, just thrombectomy. Now you have sorry.
But half did, yep.
Right. And then the question is, well, what's in that other half? And the large core trials are sort of the extreme opposite almost, where now you say, we're doing thrombectomy, and no, they don't have, a lot of these patients don't have good outcomes. It's better than not doing thrombectomy. But the way I look at large core trials is, we like to say it's a comparison between the thrombectomy versus the medical therapy. And as I said earlier, there is no medical therapy. So the large core trials are a perfect nidus or a perfect focus to figure out what those medical therapies could be. And so from a trial design standpoint, every single recent trial is now tailoring, and a future trial of neuronitide will probably and hopefully do this, tailor to patients with larger strokes at baseline, and specifically those, not the ones with the absolutely most severe strokes and not the ones with an aspects of 8 to 10 who are very likely to do well with revascularization, but those patients in between in that wide range. And that's the majority of patients that we see. So I think there's a good role for using adjunctive drugs. The difficulty is that they have to be used in conjunction. I do believe that revascularization is important. They have to be used with thrombectomy.
Thank you. Questions from the audience?
This might be a little bit of restating what you just said, but this more in a cynical perspective, which is that the neuronitide, the signal effect of thrombectomy was so high that it drowned out any potential signal effect of neuronitide, right? And by being optimistic and saying, okay, we're going to do large core, we've now showed people have a higher chance of MRS of 4, right, than death or MRS of 5. We're going to take somebody that's already sick and hope to have a signal effect from the drug Whereas cynically, I would say, like ICH, the signal effect of the ICH is so high that any sort of therapy that we've done, short of, Pradia's and Enrich's subgroup, is the reason why all the studies have been negative. So that's where I would be a little bit cautious to say, if we're starting to do large core, are they inherently, so the signal of that large core is so large that, or so significant that, adding a protective drug may get drowned out. So.
Yeah, I would say, Jens, it's hard to challenge me to be more cynical, because I take myself to be fairly cynical about this. But there's put it yet a different way, a third way, corresponding to what I said and then what you said, is that, there's a risk and a determination of how well or badly that the patient's going to do based on their disease, right? How bad that hemorrhage is, how bad the ischemia is. That may or may not swamp things. So with a large core, yeah, if you go down to an aspects of 0 or 1 in an older patient where the recovery is not going to be as good, yet you're really pushing things. So the effect of the disease itself or the disorder is just going to swamp everything, no matter what you do. There's a different effect of the thrombectomy than there is of the drug. The challenge has been to design trials that can pull apart those different features. And what I've found very interesting is that, and this is where the imaging is critical, is when, even forgetting about adjunctive drugs that are cyto or neuroprotective, the most common adjunctive drug used is thrombolysis. When you want to study the effect of thrombolysis, you study it with patient flow, with serial imaging and angiography, with and without thrombectomy, and you see what happens. And this is where in Timeless, you would think that Timeless was a study, it was a study of tenecteplase. You would think that Timeless was a study purely of endovascular therapy. And that's because the vast majority of patients needed and required thrombectomy. It was not part of the protocol. It was required because the thrombolytic that was being given didn't thrombolyze. So that the drug did not work in those patients. This is no different than what we saw with alteplase in Swift Direct. Same thing. That if you look and you say, did the drug thrombolyze? Thrombolysis to me means lysing a clot. The answer, based on the imaging, is no, it did not. So, we have to move away from the practical aspects of, I'm going to give this drug that's called a thrombolytic, and therefore it's a thrombolysis trial, and therefore that's what I'm seeing in the trial. That's not true. Maybe the thrombolytic that you're giving is not thrombolysing at all. Is it a neuroprotective? Or when you get into the detailed mechanisms, people, will say, well, my drug does X, Y, and Z. It's only regenerative, or it's only, neuroprotective, or it has an antithrombotic effect. I say this all the time, and people laugh about it, but I sort of plug my ears and I go, I'm sure you have a nice drug. Everybody has a nice drug. Otherwise, nobody would be talking about it. You got it up to a certain point. It's time to prove it in humans with stroke. The point that I didn't mention is, that comes up often is, and in recent years, is what's going to happen in the next stage? Is there going to be one drug that's going to make it? This was asked about Neurinotide, and the answer came several months later, where the answer is, first of all, Neurinotide didn't make it yet. If they take the right approach, it will. But what's happened in the field is that there's not going to be one drug. There's going to be multiple drugs, because I truly believe that what we saw in neuroprotective trials from many years ago, all these drugs work. They work to different effects in different patients, so. I think the future is bright.
Thank you very much.
Thank you.